Friends, welcome back to my channel, and I'm here as a continuation of the series on ancillary therapies in mechanical ventilated patient. So let us start. So the last time we talked about thromboprophylaxis, and this time we start with the fast hugs, that is fast hugs H, that is head end of the bed, which is to be elevated, and all intubated patients must be maintained in semi-recumbent position between 30 to 45 degrees elevation, and it of course reduces the chances of gastroesophageal reflux, thereby preventing or avoiding aspiration into the lung, and of course preventing colonization and formation of ventilator associated pneumonias. So it's a very established fact that when the intubated patients are kept in a semi-recumbent position, you can avoid these threats, which can be at times life-threatening. So as I said, you can see the angle here, and this patient is probably well placed with his head end elevated. Talking about U, that is the prevention of the stress ulcer prophylaxis. It is used in patients with a high risk for stress ulceration, especially for those who are on mechanical ventilation for more than 48 hours, patients who have coagulopathy, and of course the PPIs, which is same as H2 blockers. And here I would like to say that of course we need to actually start with a PPI for a patient who is ventilated. Now we are talking about G, that is fast hugs, HUG, that is glycemic control. And the primary aim is to keep the sugars between 150 to 180 milligrams per deciliter. There should be a strict blood sugar control levels, where we should aim for these kind of sugar levels. But there were few studies which has a very tight control of sugars between 80 to 110 milligrams per deciliter, and there was increase in the incidence of hypoglycemias, and we have to be really very careful about the hypoglycemic episodes, especially for those who are sedated, paralyzed, and critically ill in our ICUs. Now, the fast hugs, that is S, which stands for spontaneous breathing trials, and this is the best way to determine suitability of discontinuation or weaning from our mechanical ventilatory support. As I said, SBT, a classical SBT, is the one where the patient is still ventilated but with a pressure support of say about 5, where it is considered that it is negligible pressure support, and it is classically called as SBT. So it is nothing but a spontaneous awakening trial also, that is SAT. So daily SAT or and SBT for 120 minutes is what should be our target, and watch for RSBI, that is rapid shallow breathing index, and it is given by the formula of respiratory rate divided by tidal volume, which should be less than 105, where this is an objective parameter where which can denote and which has a bearing on the winning probability of the patient. And now there are so many new machines, especially the G ones which we use in our ICUs at present point of time, which gives us ready-made RSBI exactly on the monitor of the ventilator, and there is no need to calculate it, and it gives us in the figure, say if it is less than 105, or say if it is 98, probably this patient is ready to wean. And as I said, SBT, which is with a pressure support of at least like 5, it's a minimum support, or maybe even till 7. But if you have a pressure support of 5 to 7, this patient is ready to have even a TPS trial, and it is as good as that the patient is off ventilator. Now talking about the B, fast hugs bid, that is B, bowel care. The bowel evacuated regularly to prevent impaction of the stool, a liquid stool softener to prevent constipation or impaction administered once per day, and adequate fluids which should be given to prevent the dehydration. So this is the B component of the fast hugs bid. And then of course it is I, that is indwelling catheter removal, or the infection control policies and protocols. So there should be a daily assessment of need of the indwelling catheter, and there should be discussion on the rounds whether can we remove any particular tube, like say central lines or arterial lines or Foley's, and so on and so forth. So if the catheter is needed, a proper care and the daily inspection of the insertion site for inspection, for infection, collection or bleeding has to be very vigorously and with a very vigilance. This needs to be monitored. So I think I'll stop here, and we will talk about the aerosol therapy in the next video. That's all for now. Take care. Bye bye.